This is the collaborative effort between Lenox Hill Neurosurgery and the Journal of Neuro-Oncology and the tumor section, where we highlight recent publications in the journal and we speak with their authors and we kind of discuss the relevance, the results, and how it's going to influence clinical practice, what they found, straight from the horse's mouth, if you will. And today we're pleased to have what I find most interesting is the multidisciplinary, kind of institutional effort here for a recent paper. And so why don't you guys introduce yourselves one by one, tell us about the paper you wrote, maybe even give us a little insight into how you all know each other, because this is an intellectual powerhouse group that I'm proud to have here today. So welcome.
Thanks, Randy.
Hello.
Very good to be here. Thanks for having us. Always a pleasure and really a privilege to be on Tumor Talk today. I'm Khalil Abdullah. I'm an assistant professor of neurosurgery at UT Southwestern, and I run a brain tumor research program here. These wonderful gentlemen here are the authors of the study, which I'm happy to be a part. I'll introduce actually Tariq El Ahmadiyya, who is a fellow at Memorial Sloan Kettering and was our chief resident from last year, who can give you a little bit of a rundown along with Ali Haider and Paolo Palmisciani.
Yeah, so I'm Tariq. I'm one of the fellows at Sloan Kettering this year, clinical fellows. And I know these guys, Ali and Paolo, for maybe about 2 years now. We've been in touch and collaborating on different projects. Interestingly, Paolo is from Italy, from Sicily, and he's been instrumental in pushing these systematic reviews and interesting questions all the way from across the Atlantic. So it's pretty interesting, and I'm excited to be here. Paolo, you want to introduce yourself too?
Yeah, thanks for the introduction. I am Paolo Palmisciano. I'm a clinical and research fellow in Catania at the Canizzaro Hospital. And I'm honored to be part of such an amazing team. And we are working hard, and we are happy to have had the chance to have our paper accepted at JNO.
And last but not least, just to introduce myself, my name's Ali Haider. I'm a medical student at Texas A&M based in Houston, and also I do research at MD Anderson Cancer Center in the neurosurgery department. And I got to know Tariq over the past few years, and we started collaborating on some work. And Paolo's been, a great driving force as well, and Dr. Abdullah, and it's an honor to be here.
Thanks so much, guys. Paolo, you want to share your screen?
Yes, thanks.
So this is a pretty controversial topic, I guess, and I'll let you guys introduce it to kind of walk through it. We're pretty informal, so don't be alarmed if I stop you guys. And we are also interactive, so anyone listening can kind of chime in, and we'll ask questions as it goes.
Okay, thanks. So first of all, thank you all, to Dr. D'Amico, Dr. Sheehan, and the editorial board of JNO for accepting our paper and for allowing us to share the findings to the Tumor Talk. So we present our systematic review and meta-analysis comparing the roles of bevacizumab and lead in the treatment of radiation necrosis from brain metastasis. So our idea was inspired by one of the most common challenges in the management of patients with brain metastasis. Indeed, the occurrence of post-radiotherapy radiation necrosis often worsens the clinical status of affected patients, and available treatments are often not curative. Bevacizumab and lead recently showed favorable results, but comparative data are scarce, and it is difficult to actually conduct two arms controlled trials. For this reason, still, indications for choosing one strategy above the other remain unclear. And so we decided to analyze the literature and actually compare the treatment outcomes of these two modalities. Very, very briefly, I will do an introduction of radiation necrosis. So basically, radiation necrosis usually occurs 3 to 12 months after completion of radiotherapy, and it originates from delayed local tissue reaction characterized by inflammation, hypoxia, and necrosis. Incidence ranges between 5 to 25% and is variable based on radiation therapy protocols. As regards clinical and radiological findings, there are no specific findings indeed, because symptoms are mostly related to the mass effect of the necrotic foci and depends on their location and size. While at imaging, sometimes radiation necrosis have features that overlap with brain metastasis recurrence or progression. For example, it may appear with peripheric rim enhancement, central necrosis, and surrounding edema. But advanced technologies may support the diagnosis. In addition, biopsy may be done again to confirm the diagnosis, but unfortunately, there is the intermingling between necrosis and tumor cells. So still biopsy carries some risks of uncertain, incorrect diagnosis. In patients with large and symptomatic lesions, treatments are usually focused on relieving symptoms, decrease lesion volume, and stop progression. And for this reason, other than Bevacizumab elite, which I will describe later on, there are also other treatments. First of all, we have steroids, which are used as first-line option. However, although they have anti-inflammatory action, they do not have a curative role. They are used only for palliation. And also, if they are used for the long term, we all know that they may cause severe complications. Then, most management strategies are focused on limiting the use of steroids over time and wean off them when possible. So other than that, we have surgical resection for lesions refractory to medical therapy, but surgery carry many risks. And some studies also presented results on hyperbaric oxygen therapy, vitamin E, and pentoxifilin, but their evidence is limited. So in the necrotic foci, we have upregulation of VEGF due to the prolonged status of hypoxia. This triggers angiogenesis, increases vessel permeability, and also damages the blood-brain barrier, favoring the onset of brain edema and neurological impairments. Then Bevacizumab, by acting directly against VEGF, has the ability to reduce edema and improve symptoms. However, it has no persistent anti-inflammatory effects. And then when the treatment is stopped, patients may have lesion progression and they have back their symptoms. In addition, unfortunately, Bevacizumab carries some risks of bleeding and thromboembolism, and also has been related with complication in wound healing. So that most studies suggest patients to wait 6 to 8 weeks after cessation of treatment before having surgery. As regards LIT, it has the ability to remove the primary sources of VEGF directly by thermocoagulating the abnormal vessel in the necrotic foci. Also, it is less invasive than surgical resection, as it is delivered through a single borehole access. Similarly to Bevacizumab, also LIT has many downfalls. Indeed, may not be recommended in patients with large lesions, especially if located close to eloquent brain regions, because it may cause some complication. And also, it is still a surgical procedure, so has intrinsic risks related to surgery and the anesthesia. The current literature shows that both treatments are actually useful to treat radiation therapy. However, most studies are single institution and retrospective and have a limited number of patients, which is not enough sometimes to reach statistical power for clinical significance. And in addition, there is in the current literature, there is only one study published by Dr. Kian's team, directly comparing the two treatment modalities. We then decided to focus our analysis on the treatment outcomes with the most important impact on routine clinical practice. In particular, we studied the post-treatment symptomatic improvement as described in physician assessment at post-treatment follow-ups, the weaning off from steroids, which is the stop of steroid therapy administered before bevacizumab or lit, the rates and types of radiological responses assessed at 6 months follow-up using the RANO criteria, and also rates of progression-free survival and overall survival. So we conducted a little research up to April 2021 using the 4 databases as shown in the slide. And we included series of patients with radiation necrosis from brain metastasis treated with bevacizumab or lit. Studies were included if they reported the diagnosis of radiation necrosis at imaging or histology. And we decided to remove from the analysis all the case reports in order to limit the selection bias of our study. In total, we included 18 studies, 9 reporting the use of bevacizumab, 8 reporting the use of lit, and 1 directly comparing bevacizumab versus lit, the one we saw before. In total, we included 291 patients, 143 were treated with bevacizumab, 148 with lit. Of interest, 14 patients in the lit cohort received late courses of bevacizumab for refractory lesions. However, we decided to keep those 14 patients in the lit cohort because the treatment outcomes reported were referred to the period before receiving bevacizumab. We found that median ages between the 2 cohorts were similar, and brain metastases mostly originated from lung cancer, melanoma, and breast cancer, and patients were mostly treated with stereotactic radiotherapy. As regards adverse event, we noted that in both cohorts, rates were low and most complications were mild. The only exception were one case in the bevacizumab cohort experiencing DVT with pulmonary embolism, and another one in the bevacizumab cohort experienced serious gastrointestinal bleeding. As regards the lit cohort, one patient experienced intracerebral hemorrhage, and another one contralateral hemiparesis. So in the bevacizumab cohort, we found that protocols were highly variable with heterogeneous cycles per patient and dosages. And this supports the fact that the effect of bevacizumab is likely related to its anti-angiogenetic role rather than its posology. As regards lit, we found that both NeuroBlade and Visualize platforms were used across studies included, and that patients treated had a median post-treatment hospital stay of 1.5 days, which was lower than the reported rate of 3.9 days for patients treated with surgical resection. Finally, we also found no significant differences in mean number of lesions per patient, nor in pretreatment lesion volumes. But we noted that patients treated with bevacizumab actually had larger lesions compared to patients treated with lit. As regards eloquent versus non-eloquent regions, unfortunately, we could not assess differences between the 2 cohorts due to the limited granular data in the literature. So as I mentioned, we analyzed the clinical outcome data, and we found that symptomatic improvement was not statistically significant different between the 2 cohorts. And similarly, also steroid weaning off was not significantly different between patient treated with bevacizumab and patient treated with lit. As regards radiological outcomes assessed at 6 months, we found that patients treated with bevacizumab had statistically higher rates of partial response when compared to patients treated with lit. Specifically, a partial response means that patient had the reduction in lesion volume and or surrounding edema as compared to pre-treatment data. In contrast, we found that patients treated with LIT had significantly higher rate of stable disease, meaning absent or minimal change in lesion volumes as compared before treatment. And finally, we found that there were no significant differences in rates of complete response and progression-free disease between the two groups. We also analyzed survival outcomes and found that there were no significant differences in median progression-free survival and overall survival between the two cohorts. However, we found that patients treated with LIT had higher survival compared to patients treated with bevacizumab, probably because patients receiving LIT had better baseline performance status in order to be eligible to receive surgery. However, we could not assess the actual strength of baseline performance status in our cohort because data in the literature was not available. So our study has some limitation owing to the fact of the heterogeneity found in the literature. Indeed, as mentioned, most including studies were retrospective and from single institution. We also were not able to investigate possible potential clinical confounders, such as eloquent versus non-eloquent lesions or baseline clinical status of patients, because granular data were not available. Data on lesion volumes were available only in few patients, and then our statistical analysis might be limited. And also follow-up intervals were heterogeneous, and most studies stopped their follow-up at 6 or 12 months. In conclusion, we found that both strategies are effective and safe in the treatment of patients with radiation necrosis from brain metastasis and showed comparable clinical and radiological outcomes. In particular, we found indeed that radiological responses at 6 months follow-up were different, with significantly higher rates of partial response in the bevacizumab cohort and higher rates of stable disease in patients undergoing LIT. As expected, LIT might have been used in patients with smaller lesions and better baseline functional status, while bevacizumab in patients with larger lesions and located in areas not accessible with surgery. Thank you for the presentation.
No, thank you. Great job. I really think what struck me originally about this, aside from the fact that it's a fairly controversial thing, is that it's a well done meta-analysis. I think you guys put together a nice paper. I think the arguments that you guys make are good. Everything about it came across very, very smart, and I think informative as well. I think it's what's interesting about the result that you have is that it shows you that from an outcome standpoint, you're dealing with two things that are going to have good outcomes. They both are effective. They both produce similar outcomes, and it argues for really a patient-directed kind of targeted treatment on who you're going to use this for. How is this, or have you guys used this data, I guess, to influence how you're approaching patients with this? And do you have an algorithm that you follow?
I think that's a great point, Randy. I think one of the things about this analysis is that it is limited a little bit by the data that we have available. In a lot of these cases, 6 months was an important time point. And with LIT, for a lot of patients who are good candidates, what we end up seeing is radiographic non-response for a significant period of time. We get good clinical responses, but I think there's a more durable response for well-selected patients. So if anything, some of the data in this study is a little bit under-impressive in relation to what we see for, again, as you mentioned, patient-directed, well-selected patients. So, some of the things Paolo talked about, which were really critical, there's a general, I think sometimes there's a misunderstanding of this as a non-invasive procedure. So LIT is still get general anesthesia. Patients still can be in the OR for 4, 5, 6, if there's multiple trajectories, sometimes, hopefully not, but sometimes 7 hours. And so you do put someone through the stress of surgery. So when you make the decision to either treat with Avastin or LIT, Sometimes size comes into play as well. Although, I have done staged procedures where you've got a large lesion in a patient who's not able to tolerate Avastin, and those can still work well. So yeah, I think to your point, I'm not sure that we have an algorithmic approach just yet, but it definitely is utilizing some of the data that we have to try and formulate a better way to individualize care for people. You're muted, Randy.
You'd think I'd be a professional at this by now. Yeah. No, I think the key thing is that, it's not, you're not shelving one of these treatments, right? They're both effective and they're both options and they're viable options for you. And so, someone comes in and they've got a history of, GI bleeds and you're going to lean towards one thing versus the other, I think the other thing that obviously you guys didn't address is the general kind of prognosis of people with metastatic cancer, right? Which, there's definitely an argument if someone's kind of in, unfortunately, the last throes of their battle with cancer versus someone who's got, oligometastatic disease to the brain with symptomatic radiation necrosis. So overall, I think that's fantastic. Is there anything about this that was kind of shocking to you when you looked back at the data?
Well, actually, from my point of view, I saw that when I started to gather the data from all the included articles, I thought that, as you mentioned before, I might have found actual differences, maybe one treatment and the other. So I thought I would have found some more significant results in our analysis. And actually, I didn't. Indeed, as Dr. Abdullah mentioned, probably the studies we included were focused on individual patients' cases. I mean, we compared the treatments, which are in some parts difficult to compare. So we tried our best to standardize our analysis, but still, we could not, we could not find some confounders. We could not base our analysis based on that. So
yeah, I noticed that too. I mean, if you go back to your slides, even the overall survival slide, you're seeing what looks like a hefty boost in overall survival, but it ends up not being statistically significant, right? Is this kind of what you're alluding to? Things that when you first saw the numbers, you were like, oh, this is going to be better. But when you look at the actual numbers, and what argument is there for that? Do you think it's just the range?
I think,
is there a way to parse that data out?
Actually, the thing with this, and also for the reason why we had some differences, is that all the paper we collected had some, so the follow-ups were not standardized. So we had many papers with 6 months, 12 months follow-up, especially in the Bevacizumab group. So of course, the survival rates in that case were lower because of many dropouts. And on the other hand, lead studies were longer. For example, we got a couple of prospective multicenter studies with even more than 12, 24 months follow-up times. So our findings were probably not significant also for that reason.
Yeah. So when is the, who's doing the study where you do laser followed by bevacizumab? Are you guys recruiting yet?
No.
No one's combining it?
I don't know. I mean, in Italy, where I work, we are not.
No, I'm mostly joking. So my real question is, what's the next step? Where do you guys go from here with this? Obviously, it's interesting data. I'm sure it's not just a one-off. Obviously, you have an interest in this, and so any good research generates more questions. And so where do you go? Where do you take this from here?
Tarek, do you want to mention the study that you're doing at MSK?
So yeah, there isn't anything formal yet, but I think the next step would be a potential clinical trial or something prospective that would randomize patients and standardize the basic patient characteristics. Because as we said, here the patients are very heterogeneous. It seems like the comparison is a little bit apples to oranges in a way. I think the lesions were pretty significantly big on the Avastin side, and that biased things a little bit, especially with the follow-up of the lid as well. I think going forward and something that we missed in the study was the surgical arm as well. And that is something we did not include in our analysis or in our search. And it would be interesting to look at that as well. Going forward, the question would be, if you want to randomize, do you use a 3-arm randomization kind of thing, or would the lid go under the surgery versus the maximal medical therapy on the other arm? And I really don't know the exact answer to this question yet.
I don't know if anyone does, man. I think that's the problem. It's a complicated question, right? I mean, surgery is not drastically different from lit in terms of, time in the OR, risks of anesthesia, things like that. But obviously it depends on where your lesion is, and demonstrate, finding equipoise to conduct that study is going to be very, very difficult.
Yeah, I think, sorry, I was going to say to that point, one of the things about lit that is a true benefit over surgery, and also to some extent bevacizumab, is that it's a little bit easier. In fact, it's much easier to continue with whatever systemic therapy a patient might already be on. So in patients who are on immunomodulating drugs, those patients, and this has been shown out of MD Anderson very well, is that those patients do better when they're treated concurrently or in close proximity before or after the procedure. So you're not disrupting that treatment in order to treat the radiation necrosis. And I think that's a very big deal. I think it's really important for us to do studies like this one, because like any technology that's relatively new, and I think lit is getting to the point where it's not that new anymore, but it still has barriers to adoption. Sometimes that's outside of neurosurgery. Our referring doctors we have to share this data with them so they're more familiar with it. So when they see these in the community or in practice, they're able to recognize this is a treatable entity by a neurosurgeon or by a multidisciplinary team and be able to send that in. And also, department to department, being able to kind of get over the hurdle of this being considered new or questioning what the indication is. So there's that element of it, but I think it's still difficult for us sometimes to, in a field like ours where the numbers are smaller, to really parse through the data and try and pick out a 62-year-old with a KPS of 90 versus a 75-year-old with a KPS of 60. One is on, an immune modulator, and the other one has a history of avascular necrosis. I mean, there's so many variables that affect the complexity that whenever we can do a study like this, I think it is very helpful to try and parse through it like we're doing, so that we can, help build on the next set of investigations like you alluded to.
Yeah, absolutely. I agree with you. I think, like I said before, I think this is a great study, very well thought out, a great stepping stone to other ones as well. And I think, on behalf of Jason and the JNO, I appreciate you guys submitting and publishing with us. It's great. So we're about 2 minutes from the 4:30 mark. We like to keep this short and sweet. That's how we keep people coming back for more. Any final words from anyone before we sign off? No,
Randy,
I love it.
Thanks for having us.
Yeah,
Thanks for the opportunity.
Yeah, so this will be up on YouTube. We can send a link out to you guys in the coming days or so. And it's always a pleasure. Please continue to publish with us. Come back. We look forward to hearing from each and every one of you, and good luck in your futures to those who aren't yet in their office.
Thank you. Thank you very much.
Sure.
All right, guys. Take care. Bye-bye.
Bye.